We welcome you all to Talk the Talk. My name is Janine Stiene,
And I'm Toni-Ann Antoniato.
the Masters of Myofunctional Therapy.
Together, we interview physicians, dentists, and other professionals to learn how their expertise can benefit you, your child, or your patient's speech and language skills and complement the services they are receiving. We welcome you to this episode of Talk the Talk. Joining us today is Henning. Autumn is a speech language pathologist specializing in oral facial function and development throughout the lifespan. She owns and operates her own private practice, Chrysalis Oral Facial, which is located in Greenville, South Carolina. As a speech pathologist, certified oral facial myologist, and an IBCLC, Autumn has developed and taught thousands of professionals in her continuing education courses and through her professional consulting services. Autumn is also currently an assistant professor in the Department of Communication Sciences and Disorders at the University of Kentucky College of Health Sciences. Welcome, Autumn, to this episode of Talk the Talk.
Hi.
Hello, thank you for having me and that great introduction.
I'll just say you're quite busy. I'm grateful that you were able to even carve out some time for us today. So thank you.
Yeah, absolutely.
Yeah.
So it was obviously such a pleasure when we got to meet you at the American Academy of Pediatric Dentistry in 2023. You were there as a speaker. We were there as an exhibitor of Spot Pal, our new product, so to speak. And you came over to the booth, and you will be the first to say that you had some initial hesitations when you briefly heard about this new tongue training tool. However, after speaking with us and trying Spot Pal for yourself, you became such a huge supporter of the product. It's been such a pleasure working together with our shared mission of changing lives of individuals through their oral function, and we are just insanely grateful for your support.
Yeah, you said it so nicely. Hesitation. I had some challenging questions. And other therapists have kind of challenged me on it. Like, how is this different than a habit appliance? You're punishing kids and hurting them. And I'm like, guys, these are like speed bumps. They are not like jabs, right? The tongue pokes. And yeah, I had a lot of questions about how the growth would happen if we're, using an appliance and locked in, and how customized it was and all of that. And I came out of that away from your booth. I was like, dang, they converted me. But truly, it's been a staple in our practice, especially for, habituation. So, you have those patients that when they're here, when you're cueing them, they got it. But they leave here and, it's basically, their mom hounding them. Where's your tongue? Where's your tongue? Where's your tongue? But it's out of sight, out of mind. And so this provides a really good ongoing tactile cue to help that habituate. And it's really helpful.
Well, that's amazing. And it's so nice to get feedback, especially after utilizing it with patients and seeing a difference. I think that speaks volumes compared to us having to, this is what it does. This is what it does. I think it's nice to hear that from a provider who's utilizing it.
The outside perspective. And, me, myself, I make it a point to, I'm not promoting any courses that I haven't taken. I'm not promoting any products that I don't find helpful or useful. That's just my ethical thing. And I use Spot Pal for me, especially during exercise. What is it? Lift Pal?
Yeah.
For weight training. And then Sport Pal. Yeah. Just to it's really hard to keep your tongue up and lips closed during aerobic activity. And so, I put it in on my Peloton and working on that.
Yes.
I love it. I'm impressed that you can fit in the Peloton with everything you have going on. So now you're an inspiration on top of that. And there should be no reason that I'm not exercising. Got it. Okay. I have my little walking desk next to me.
Good.
It just sits there.
I would fall.
No, but we couldn't agree more. Obviously, I use it clinically within the practice too. And it's just that, meeting parents where they're at with the home practice because life is busy and they do run from one thing to the other thing. And if we can make the practicing easier for them, they're so grateful. So it's
Sure.
been great for
For
that.
sure. Yeah.
Yes. All right. So, Autumn, as an SLP certified myofunctional therapist, IBCLC, business owner, let's start with a little bit about you telling us about your journey and what has allowed you to become such an accomplished professional in this field.
So, if you told me that I'd be doing this, 15 years ago when I was in grad school, I would have thought you're crazy. I truly never set out to be a business owner. I never even thought about creating a course and teaching continuing education or being a, international presenter or any of that. It's so cool how it just kind of naturally evolved there. I thought I was going to work with trauma, like head injury adults.
Wow.
And yeah, I got out of school. I went into the schools. And, I was grateful for that experience. It opened my eyes up a lot to what school therapists, have on their plate and, the resources they have or don't have. And it was really hard. I was in a state that did not have a caseload cap. So,
Wow.
again, some therapy is better than no therapy, but 20 minutes a week in a group of 5, you know.
Yeah.
So there was a pediatric feeding clinic, like an intensive one in my town, and like they invited me to come observe, and I never thought I'd do pediatric feeding, like just didn't cross my mind. And yeah, I moved over there, and I say pediatric feeding was my first love,
Yeah.
and that was like the gateway drug. And then, I tell about it in my TOTS training course, kind of my evolution, but I'll give you the Cliff's notes. So there was a patient that just couldn't solve the puzzle. I was a brand new therapist. I was like hot on the trail, like trying to figure it out. And the very more experienced therapist didn't know what to do either. So I just kind of researched and, came up with this hypothesis of posterior tongue tie. Guys, this was 2010. Like,
Yeah.
you have to remember how long ago that was. And there were not the big names. Like, Zoggy was probably in preschool. Um, Richard Baxter,
Yeah.
high school, maybe. I don't know. There were like, this was like a very minimal topic, and I certainly wasn't trained in it in grad school. So yeah, I had this case and went through it and, found out there was a posterior tongue tie, learned how to assess for it and what to look for. And then I started thinking about other patients and like how many had I missed and how common is this? And if people don't know what to look for, then how are they identifying and helping? And it made me think of these patients that are there for years and years and years, right? So from there, I was working on feeding, and then there was kind of this, I call it the ones that fall through the cracks. So maybe they don't have true feeding or speech issues, but they take forever to eat. They're picky. They have mouth breathing, like these other things, these other quality of life things. And so I started working with kids and then adults because some of this is genetic.
Yep.
And when I talk to kids' families about the tongue tie and how it can be related to sleep apnea and TMJ and those sort of things that kind of cascade and evolve as we get older and orthodontic relapse and all the things. They would get their eyes really wide and they'd say, well, what about me? Do I have one? And so I, other than grad school and in my rotations, I've never really worked with adults. especially in this particular niche. So I did get some more training in myofunctional disorders. So my first area was SLP. Then I got my COM, certified orofacial myologist. And then I ended up getting my international board certification for lactation consulting. And I call that affectionately the oral function trifecta. That really covers, from birth to elderly, as far as, articulation and swallowing and bottle feeding and breastfeeding and, everything in between. So fun fact, first one in the world to do that one.
Wow.
Really?
Yeah, that's my slight little claim to fame, but I thought that was super cool.
Oh my God, beyond cool.
Yeah. So, really just having that really well-rounded 360 picture of things. And so, I was working and seeing patterns in patients and figuring out what worked, what didn't work. That's why they call it clinical practice.
Right. Yep.
And so really honed my skills, and I was seeing patterns and what was working. And so honestly, therapists would call me and say, "Hey, what's this tongue tie thing?" Like, this is not a 20-minute conversation.
Right.
There's like a whole science and art to it and sequencing of it. And, so I started basically word vomiting. I had this, still have it, this green notebook just with blank paper in it. That sits next to my bed because, that's the time you think of good things, or in the shower, right?
Oh
Or
my
in the
God.
car.
You and I are so similar in so many ways. It's actually a little alarming. I think we might have been separated at birth.
So I pretty much would draw things and do flow charts and word vomit in there. Okay, this is how I decide this. This is what I do next, whatever. And so I came up with my E3 model of care for treating patients that are affected by tongue ties. And so it was kind of like a side hustle. And, I didn't do any advertising, guys. I don't know how to do any of that. I really put on Facebook. This is how amateur. You ready? So it launched. My first course was in October 2016. And I just put on our speech Facebook groups. Hey, anyone interested in tongue tie? Put your email in the comments. Literally, that is it. My first course sold out.
Wow.
And yeah, it was, I think 44, 45 people. Yeah. We busted out of the room. And so, it just grew from there, and it was designed for people working on the oral function. So myo, feeding, speech, those things. And honestly, in droves, dentists, doctors, nurse practitioners, lactation consultants, chiropractors, we're all wanting to know how this all fit together. And even though they're not doing the oral therapy per se, really integrating it, and kind of the left hand knowing what the right hand's doing. So yeah, I just did my 50th course of TOTS training.
Wow.
Yeah. And then it I was working in nonprofit and basically doing 30 hours there. I was clinic director and seeing patients. And then I was traveling on the weekends to do courses all over the place. And then I was seeing some adults on the side because the nonprofit I was at, their mission was children. And so it just got to be too much of okay, if you're an adult, you come to me over here. If you're a kid, send over here. And meanwhile, I'm trying to go on these courses. It was just too much. And so the place I was at was pretty, much very Medicaid heavy, very much severe syndromes, more medically complex patients, right? Whereas, myo is less of that,
Right.
And so it just wasn't compatible with where I was, and I saw a need in the community. And so in 2020, we went all in.
Wow.
So my husband and I both left our full-time jobs and
Wow.
started our business. I was full, treating 40 patients a week within 3 weeks. Had to hire at week 7, and just kept growing ever since. So, that's kind of that was long-winded, but that was
Oh my God, it's such a great story, though.
is.
It's really, it's nice to hear from the beginning how it's evolved.
Yeah. And very quickly too for you. It's like ready or not.
Yeah. I mean, it's gone fast. Yes.
Yeah. That's wonderful.
Do you have a great group of professionals near you, like a great interdisciplinary team that you're working with?
So yes, and that, I mean, that was a work. That was one of the hardest things to get going, was getting a team that understood it,
Yep.
got it, referred, understood how it worked together and helped them. The networking piece was, that took a long time, and, I think I cracked the code on it. So currently we have 8 release providers.
Wow.
Yeah. Yeah. And like, I vet them. I have a whole survey that I go through. Like if you want me to refer to you, I have to know like where people are going. We have to have an open line of communication for feedback. So yeah, 8 release providers. We have 3 sleep physicians. We have 1.5 ENTs.
Working on that.
It's just an EN that it lost the T, right? Because
we're growing. We have 8 orthodontists. And yeah, I mean, we have a TMJ dentist. Who else? Lactation consultants, and honestly, we have a lot of other SLPs. Yeah, basically, they're doing their thing, and like this is super specialized, so when they are feeling like, man, there's got to be a missing piece, or we just cannot get that articulation and those sounds under control, like there's a missing component. And so they'll come to us for our piece of things, and then they go back to their SLP to finish that out and clean it up. And so that's been really surprising to me, working with other private practice owners. And, just everyone, I feel like you do better when you're doing what you love. Like, not knocking on people doing, stuttering or language or whatever. It's just not my thing. And I'm not great at it, and I don't want to do it. So, I get to do what I love and what I feel like I'm talented at, and I can be the best therapist that I can be that way.
That's amazing. And it's so important. I mean, obviously for the patients, but to build that team around you and have so many, that's a very big thing.
And it's been, I mean, it's literally been years. The main orthodontists are number 1 referral source. I worked very close to them for 5 years and got nothing. And then there was one case where they got to, I helped, like, this patient came back to them, and this open bite was like nearly closed. And they were like, what have you been doing? Yeah. They sent me a cake that week.
I love it.
Yeah. So I think like proof is in the pudding.
Yeah,
and,
absolutely.
Dropping off research to people's offices, that never works. That never feels good to them. I think that personal relationship is the big thing. And that's one of the biggest things in my course, is that people are like, well, this all works if you have a team. Great for you, Autumn, but I don't have a team. Let me find an airway centered orthodontist. Well, they're not going to drop in your lap. Right.
Yep.
Like, you have to get out there and pound the pavement. And maybe they're not right now. Like, but you can help them get that way. Like, I have like a little bulletin board, and this is from one of our main orthodontists. And he wrote, "Thank you for helping me be a better orthodontist. this is the best surprise of my career, and you're such
Wow.
a gift to us, right?
Wow.
So like,
Wow.
yeah, I'm just looking at it.
Yeah.
Yeah, like getting a sweet handwritten note from an orthodontist, and they go into, you know, make straight teeth, and they never thought that they'd be working with 4-year-olds. And
Yeah.
um so yeah, it's just really cool, and I call it getting bit by the bug.
Yeah.
Yeah. The
Yeah,
radioactive spider. Yep. That were, yep.
it's addictive. And you have to find the right person that wants to do it
Mhm.
too. Yeah.
Definitely.
It's true. It's
Definitely.
true.
And sometimes they're, even when they're not the right person, if we can get them referring to maybe somebody, not everyone wants to treat a 4-year-old as an orthodontist. So that's
Yeah,
okay. They don't have to be that
exactly.
person, but they can hopefully make referrals.
Exactly.
Hmm.
100%.
Yeah.
Yeah.
Wonderful. All right. So a lot of your courses that you give are surrounding the topic of tongue ties. So we want to obviously go into that topic today. And you teach on the assessment and the treatment of tethered oral tissues. So going into some of those questions, what about starting with something that we experience on a regular basis within our own practice and clinic? And that being the first person who's pointing out concerns surrounding a tongue tie, even though the patient is 5, 6, 7, sometimes even older, being that first person to identify it.
Yeah, I think that's one of the coolest things. At first in my career, I had a little bit of like, um, who am I to tell them this? And if the doctor says it's not there, then maybe it isn't there, you know? But when you start seeing patterns and you see patients get better,
Mhm.
I think that makes you more confident. Um, I I tend to explain it like, hey, this is a specialty area. I have my master's degree and I got nothing on this topic, right? And, the same is true for, they get very basic, straightforward information on it through, medical school and lactation consulting curriculum, um, and dental school, all these other areas. And, it's just like not everyone can be a specialist in everything, right? So um, the other thing is I kind of explain to them, like they've seen what I've done as far as like an evaluation, how in depth, you know, we take measurements, we watch them eat, we do a full speech workup. We figure out where their tongue is resting, not just that they're not choking and gagging on foods, but how they swallow.
Mhm.
We go all the way back to when they were a baby and like full development, right? And when you can put those pieces together, and even like, I mean, we see people in their 60s, they're like, oh my gosh, this makes so much sense looking back in my life. Like I was a bedwetter till I was 8, or, I had to have headgear, whatever it is. So I think people end up feeling relief, and trust. And, I think it's less now. Number one, like there's a lot more awareness of it out there. And lots of times the parent or the patient are the ones that are like, I think I have a tongue tie. There's a
Yeah.
lot more
Mhm.
access to information with social media. Um, there's a lot more education out there. Like when I started, like my class was one of very few specific tongue tie classes for, speech and feeding therapists, lactation consultants. And now, there's a lot more.
Yeah.
Um, so I think that exposure and then, just educating in your community,
Mhm.
like a lot of people come here because they know that we specialize. A lot of people come here because they're specifically referred.
Mhm.
Um, and so, yeah. I think that's improving and gets easier over time.
Mhm.
And I think that's always going to be there to some degree because not everyone's aware, not everyone wants to be aware.
Mhm.
Yeah.
How does it work near you when you're talking with the school SLP and they're identifying a tongue tie? Do they, I mean, I did the same thing as you. I worked in the schools, was introduced to myofunctional therapy, but you couldn't do that in school.
Right.
You're like, okay, if I put gloves on, my principal would be like, what? Oh, no, you can't.
What are you
Why do you have gloves? Right. Why are you wearing gloves? I'm like, because you don't want me touching this kid. But how do they handle that in the academic setting, especially as the therapists are coming to you and looking for this knowledge?
Yeah, I mean, I think every state and district is a little different.
Mhm.
I don't know if this is, yeah, this is state. I know, so I'm in South Carolina, and about 2 years ago, they did pass that SLPs could work on feeding in the schools.
Wow.
So that's pretty cool. I mean,
Yes.
obviously, they're the academic model, but you do need good nutrition to learn. And, if you're hungry all day, like that's not going to go well. But anyway, so yeah, with school SLPs, I mean, I think it's great that they're identifying. I think it's really tough to do an adequate job of sequencing and working on, pre and post therapy and all the moving pieces in the case management piece of it.
Mhm.
And, you know, less communication with parents when you're in
Right.
school. Like, when someone's bringing a kid to therapy, you
Right.
see them every week and get to talk to them every week.
Mm-hmm.
And I know school therapists do an amazing job sending papers home and even sometimes calling or emailing. But yeah, I just think it's a different population. Um, I know it gets a little dicey because referring out, if you say something, sometimes the school can be liable for having to pay for and provide that medical service.
Right.
So I find that they tend to kind of dance around it
Mhm.
here. Like, well, maybe you should check out a consult for,
Mhm.
consider that,
Mhm.
right? Not a straight recommendation. So um, our providers are really good as far as they have little gatekeepers because they want the best results. They will not schedule a patient for a release or honestly even a consult um, without them having like the green light and seeing therapy before and after, and not just any therapy, like someone that understands the aftercare, all the implications. Um, and so they actually use my directory of like who's been trained and who hasn't. So I think that's helpful too. Yeah, it's hard. I've been a school therapist, so like I can empathize with that for
Mhm.
sure.
Yeah,
Definitely.
we see the same,
Yeah,
similar
absolutely.
here, that dancing around the recommendation, and we try to support them with, you know,
Yeah,
how to say it in a way that might not cause them to have any liability
right.
on the district.
Yes.
And I
And
think a lot are so not educated in tongue tie. And then they came out of grad school and not having that experience that they don't even realize like what the missing piece is.
Mm-hmm, mm-hmm,
right,
mm-hmm,
right. And like it's state funded and it has to be academically impactful, right? And so, there's less carryover. They get less time than private therapy.
mm-hmm.
Um, and so, it's hard. It's
Yeah,
hard to
yeah.
move forward on that for sure.
hmm We have parents who will say, they've been getting speech in school though for 5 years. So, and taking the time to kind of explain how this is going to be different. We're not going to be drilling that sound. We're going to be working on the underlying reason, strengthening the muscles, and kind of explaining all of that too.
Yeah, I mean, traditional speech therapy, when you have an underlying tongue tie and myofunctional therapy, it is just banging up against a wall.
Yeah.
And
Hmm.
I mentally can't do it and I don't do it because like I just feel like I'm inhibited. I know what can help,
Mhm.
but this is not the way to do it. And so it early on, when someone came to us for articulation or speech, they're like, why are you not working on that? I'm
Yes.
like, well, if you have someone paralyzed and you're sending them to PT and they're just like, walk, 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 it's not going to work. right? So same for speech, say, right? It's just not going to work.
Right.
And so, yeah, find that it goes much quicker doing it this way, and sticks better.
Right.
Yeah, absolutely. Absolutely.
Agreed. All right. So staying on the topic of tongue ties then, and you explained about how you are very fortunate to have created this community around you, 8 release providers, which is amazing. But what do you say to the release providers who are not talking about myofunctional therapy before and after a tongue tie release?
So I think it's a personal, I think it's like a sit down conversation. And it's a, how's it going? How can I help you? And vice versa. And what they need, what we need. And so I think speaking to someone in analogies, like, dental wise, they're thinking about structures. They don't know function, right? And I mean, physicians, it's shown that they have like 2 hours in breastfeeding education in their whole curriculum, right? So, we really are the specialists in feeding, swallowing, speech, myo. Like, that is our domain. And just because someone is a doctor or a dentist, we can hold our own. So I think having that confidence to go and sit down at a coffee shop and explain it in a way that they can get it. And I'm an analogy girl, that it's what relates to people. And I tend to say, and I say this in my courses too, who does better with a surgery? The couch potato or the Olympic athlete? They break their leg and they need a surgery. Who's going to bounce back, right?
Yeah.
Who's going to remediate the symptoms much quicker? Who's going to have more pain, right?
Yeah.
And so also I kind of play into, how can I help you? Because that's what people really want. Okay. If I've educated this patient on the front end and I've explained a lot, guess what? That's easier for you to deal with them, and it takes up less of your time.
Yeah.
And so, having that pre-therapy, and I developed a course called Therapeutic Readiness, and those are like the benchmarks that we want to hit, that I found patterning with infants, older children, adults, and toddlers, what has worked and what do we need to get beforehand. So that's kind of how I explain it. And then, post therapy, obviously, I tell people, hey, you got webbed fingers, release the webbing. Great. Now we have passive range of motion, but can you snap your finger? Can you button up your shirt? Can you write with a pen? No, not necessarily. Just because you have the right structure and the right anatomy or equipment now doesn't mean you can do that functional thing. And so my job is to develop, capitalize on that new range of motion, help them use it, develop strength and coordination and endurance. And so, we're kind of like physical therapists for the mouth and face, essentially. People tend to think about the big muscles as muscles. They forget that all of this is muscles, right?
Yep.
And so that's usually kind of what I say. And I kind of tell them like, hey, like, I appreciate if once upon a time I had people referring after the fact. And I'm like, I want to protect you. I want to protect the patient. You could have done a gorgeous, perfect release, and now it's reattached, or their symptoms are still there because they didn't change their patterns or whatever. And this family goes out and blasts you on social media and is like, oh, tongue tie's a fad. Tongue tie doesn't work. They just want my money. Whatever. But we haven't addressed all these variables and factors. So I also kind of say, like, it puts me in a bind and isn't fair to the patient if you say, oh, go here after the fact, because it's hard for me to get them in. Like I will move heaven and earth to help somebody. I'll skip a lunch or stay late or come in early or whatever. But that's not cool for me, right? And when we don't have a baseline, we're starting from scratch. We don't know what it looked like before. We don't have any measurements that we can track progress with. And if they're not moving it regularly and have learned some of those skills and decreased compensations, then afterward things are going to really heal tightly, whether you put stitches in or not, those underlayers. And so, I talk a lot about retreatment. No one wants to have to retreat a patient, right? Or, ortho relapse, things don't stick even though they're wearing the retainers or whatever. So yeah, really, I make it about them sometimes.
Yeah.
Yeah. Yeah.
Wow. What about the adult patient? What are you seeing in your practice when it comes to that adult patient that may be suffering from TMJ pain or even having issues with airway space and sleeping and all of those issues?
Overall with adults, like, it's been years of dysfunction.
Right.
Right. And there's a lot of cascade effects. Okay, you have a tongue tie, your tongue sits low, now you're high and narrow, now you can't breathe through your nose. Now, you're grinding in your sleep because you have a smaller airway and you grew long and tall instead of wide and broad. And there's all these factors, right? And so I honestly love adults. My favorite type of patient is the reluctant husband.
Yeah.
That's what I call them.
Yep.
The child's been here or the mom's been here, and then they're like, you need to go, honey. And they sit with their arms crossed and they're in my pink room and they hate their life right then. And then they start seeing progress, right? And then like they warm up and they're your biggest supporter.
Yeah.
So, I always say people only have so much time, money, and energy. And if you come out of the gate swinging and be like, you need MARPE and you need orthognathic surgery and you need to go here and there and, you need a ENT referral, all of these things, like they're going to shut down.
Yeah.
Like that's too much to hear. And so I tend to focus on what can I do for you today and right now with, hey, I'm seeing some things that may indicate we need to pull in some other professionals on this. I feel like very few people are going to be like, yes, sign me up to break my palate.
Right.
Yeah.
Right?
And so that I think we're going to talk a little bit about it, but I joke. I'm like, if I referred every mouth breather or every person with a narrow palate to ortho, oral surgery, or ENT, I would have no patients, right? Like there's a lot that we can do in the meantime.
Right.
And so, yeah, really figuring out some of the markers that help to treatment sequence, help to get the patient more bang for their buck, considering their wants and needs too, and what they're comfortable with,
Yeah.
And I kind of give them, now that you have enough experience, you can kind of give them fair warning of like, hey, I think we're going to hit a plateau in therapy and we're probably going to need this later on. Maybe they're not open to it now, but just dropping that seed in so that if it comes back up and we are going to need that referral, they're not like, wait, what?
Right. And sometimes they're seeing that not immediate, but they're seeing that improvement with just the myo, that now they're like, wait, there's more I can do and there's even better results that can happen. And sometimes they just need to kind of experience it for themselves too.
Right. Right. And I mean, I'm thinking of a patient right now who he came in, coolest guy, another business owner, so we like to talk shop. But anyway, he came in with TMJ dysfunction and had tried all the things, the splints and the mouth guards and the and massage and craniosacral therapy and dry needling and all this stuff. But no one ever looked at the function. Like, why is that muscle getting fired up, being tight, pulling the disc out of place? And, we do some measures and pain rating scales. And he was like, it's a 9. Like, I live with a 9 on the regular basis, 9 out of 10 pain. And like, I mean, that just messes with your life. You can't focus on anything when your face hurts, right?
Yep.
And so after 3 sessions, he was like, it's a 1 or a 2.
Wow.
I
Wow.
mean, so huge things just by, and he does have a tongue tie, but huge things just by like reprogram or deprogramming some of those compensations that they don't even realize they're using, getting some support for the jaw. I think it's super powerful. And, I share research, patients always want to know how long, how many sessions,
Yep.
how much will this help me, blah, blah, blah. I'm like, honestly, Joe, that depends on you more than me. How often, are you coming, or are you doing your homework? Are you following through? And, we have averages of how many times people tend to come with that specific type of profile of case. But, I do share some research, like, average myofunctional therapy can help adults reduce their sleep apnea by 50%. So, I mean, like, hey, if we can even get you 20% better, that's a huge win. It depends how far we're going to get and how quickly. That's what are the things we don't know. But, I feel pretty confident, like, with those specific things that I can help to a certain degree, at least.
Right. Yeah. And then you hope to, sometimes you get the adult patient who comes in and they've already done all the research on it and they're like ready to go. They believe in it. They're invested. They're motivated. And then you have someone who can come and just be like, I don't know, my, orthodontist sent me here. I don't even know why I'm here. And then it's a totally different approach as the therapist.
It is. And something I've found, just like business and patient compliance wise, to combat that is, number one, we created a provider guide for our referring providers. Basically, commonly asked questions, getting their spiel and script down so that they're educating, so their patient's more likely to come, right? And number two, giving them a referral pad and them sending the notes directly to us. Because then we know exactly why they're coming. Because what a patient hears and perceives may not be the clinical side. You know what I mean?
Yes.
So that's really helped with like people following through with coming. Yeah.
It's funny how similar, even though we're in totally different states and different populations, seeing the exact same things you're saying.
Exactly. Dealing with exactly the same like focus and trying to educate, but at the same time not make someone fearful of the therapy or the approach.
Right.
And I definitely feel like we say this all the time, like the pendulum has like swung a little bit where people are more knowledgeable about myofunctional therapy. The general consumer is more knowledgeable about it, even about tongue tie. I think, like you said, social media has definitely made had a huge role in that. But we still have those providers that are still so resistant. Do you find that you have the same thing by you? And if so, what are you doing to kind of nudge them along?
Yeah. So a few things. You know what? Like, I'm not here to change your mind. I'm here to give you, my experience, my patient's experience, and, be a resource to you. So I'm not going to hound anybody. That just never works. The best thing that I found is, the patient going back and being like, hey, doctor, whoever, this actually helped me. And this was my journey. And, I'd encourage you to learn more about it. So we do tell our patients, like, hey, especially if, like we talked about earlier, if they were like, no one ever pointed this out. No one, doctor said I was fine or whatever. I'm like, they're never going to open their eyes or learn any more about it if you just go on.
Right.
Yeah.
You know, they assume everything's fine. Well, they don't know why it's fine now.
Right.
Sending reports, you know, we do very minimal paperwork. It's very checkboxy. And so, you know, hopefully they have time to read them sometimes. Like I said, that personal approach, calling them up and talking to their nurse or their practice manager. Hey, here's my personal cell phone. We have some patients in common. I'd love to sit down and chat. And I tend to like go to a coffee shop just because it's like less, it's neutral.
Right.
Yeah.
Right.
Yep.
Formal. Yeah.
And I've found like the doctors that are willing to do that are the ones I want to work with.
Right.
The doctors who are like, I'm holier than thou and I know all the things and I have 500 awards and, you know, whatever. Those aren't the ones that are good for this anyway.
Yeah.
You know? So I always say choose the person, not their resume.
I love that.
Yeah, that helps. What else? Oh, you know, I think we don't do this enough because we just assume it's not going to happen. Invite them to come see
Right.
a session.
Yeah.
Right now I've only had a handful of. We've had several orthodontists come and pediatric dentists. Pediatricians, like maybe 4 or 5. ENT, we've had one. But I think it's helpful for them conceptually to like see what it is. And we're not just saying, oh, there's a little tight tissue. That must be a tongue tie. Like it's a whole, you know, 90-minute, and we're gathering multiple data points to kind of make that conclusion.
Yeah.
So, yeah, I think that helps. And there's always going to be that. And, you know, yeah, it's, I always joke when I started my course in 2016, I talk about that Imagine Dragons song called Be the Lightning, right? Or the song's called Thunder. And it talks about being the lightning before the thunder and not fitting in a box or a mold or whatever. And so yeah, that's my thing, is be the lightning before the thunder. And I feel like we've kind of done that, is we're on the forefront of it. And I think this in 20 years is going to be old news. Like everyone's going to know about it. And it's going to start being taught in programs, and you know, maybe not to the degree we want it, but at least there's going to be some education awareness.
Absolutely.
Agreed. So I think 2 years ago, someone said on the praxis for the first time, there was a Myo question, which is mind blowing, right? Because you don't learn anything about it, but let's put it on the exam that you need in order to practice, you know, for your future. And that's such a revolutionary change.
Definitely.
Yeah, absolutely. And I think ASHA has started to say like, hey, you know, we need to do some sort of education in myofunctional disorders in grad programs. I don't think that's been like hardcore, like implemented yet. But yeah, I mean, I do with University of Kentucky. I know Robin does with Brescia, which is a Kentucky school too.
Oh, interesting. Okay.
You tend to think Kentucky's like slower behind the times. No, we're cool.
Yeah. We do a lot. Like we'll do just like guest lecturing to a university. So even, you know, to do that, I don't know how much, just like you said, like maybe they don't need to go fully into it because it's probably not the best people to go into it, but for them to be able to just say like, hey, there's this whole area that you guys can, you know, specialize in or learn more about after grad school.
Just exposure for sure. I mean, that's the thing about our field is, gosh, there's so many specialties and avenues, and our scope is like huge.
Yeah.
So yeah, I mean, I think maybe an hour lecture would be appropriate. So yeah,
Yeah.
It's just hard to fit it all in, right?
I
Yes.
probably had recently sent about 10 emails to universities offering, the spring semester is coming up. I'd love to come in or virtually if it was far away. And every single university was very receptive, excited. I've scheduled some already. And then I had one, I won't say, but I did have one university that replied back and said, no, we would not like to have you. Myofunctional therapy is not evidence or research based. And I'm like, and then, I sat on it for a few days and I'm like, you know what? I'm going to reply.
You did reply?
I did reply.
Oh, okay.
And
that's what she's gotten from me, because normally she's been like, it's fine. The antagonistic Toni-Ann, that's from me. Okay, go ahead.
Yeah, so I did reply, and I replied with a ton of research attached articles and just said, this actually is very much so research-based, and also let's not forget evidence-based practice. And this has been, backed by evidence for longer than I've been in the field. So,
Yeah, I think, I think the people that want, a longitudinal, blinded, randomized controlled trial, like there are so many factors, right? Like it's hard to isolate those variables and get that research. So, I tend to say there's so many things that we do that we know works, but doesn't have like that sort of research behind it. You know what I mean?
Right. Yeah.
Like,
Yes.
Yeah.
I mean, using a mirror for speech.
Yeah.
That doesn't have like amazing research behind it.
Right.
But we know it works.
Right.
And, also ASHA has, a practice portal. It's not as robust, I would like. But it is in our scope and it is there. So yeah.
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 I mean, it wasn't too long ago that there was a position statement, right, that was revoked now, but when I got into the field, it was people just, well, Ash's position statement. I'm like, no, that's no longer valid, but people don't always keep up on that end either.
Yes. And, a position statement is just that.
Right.
Yes.
What they think.
Right. Right.
Not the law. It's not in your scope of practice because they think it's not a thing.
Right. It's not research backed.
Opinions, right? So, I think it's pot kettle.
Yeah.
Yes. Agreed.
Yeah. One thing that I want to go back to for a second, because I feel like a lot of the times, the three of us here, we're pretty comfortable and confident to go to professionals and explain our disagreement in a professional and educating way. But there's a lot of SLPs who are not there yet and not comfortable yet with that. And I think one of the things you said about letting the patient go back to the professional and explain it is just really such great advice for those who are listening that are those professionals that are just not ready yet. And I still do that a lot because, again, sometimes it's just my word. And if it's the parent or the patient that's going to that professional, it can just really help to open their eyes, especially when I work with infants. I do a lot with them. I do have my CLC. Don't have my IB-CLC yet, but I do have my CLC. And, the parent just having that intuition of like, I know this is more than what my pediatrician is telling me, right? My pediatrician's like, they'll outgrow it, or it's just some reflux, and they just know. And they go to the release provider, and the release provider sends them to us, and we go through everything, and now their baby is eating and breastfeeding and thriving. I'm like, please go to your pediatrician, talk to them.
I know. And that, I feel like us as therapists, we feel like there's this like hierarchy. But I also think patients feel that way too. Like the doctor is the authority, So I think that plays a role too. But Yep. I definitely encourage that and hope it helps at least.
I love that.
Even with egos and misinformation or poor education or lack of education, I should say. Even with that, I feel like you can have all the research in the world or poor research, right? And the person in front of them, if they are changed, if their metrics are better, if their symptoms are better, that holds more value. hopefully everyone's gotten into a medical healthcare field to help people. And so, that's how I kind of feel like, okay, if the person in front of me is feeling better, doing better, then I don't care. I'm putting my blinders on, and people can say whatever they want to say, but proof is in the pudding, right? And so I've found that sometimes it just takes a case or two, and they're like getting curious and asking questions. And I mentioned that pediatrician that was curious, and I had one case with her. Baby came back, was back on their growth curve, that sort of thing. And she was like, hey, I want to come observe. So she did. She then took my course at I taught in Atlanta at Emory, the medical school there. She came there, and then she has 9 kids. We've seen
Wow.
8 out of the 9.
Wow.
So like she was a total convert, right? And she was kind of in the system, with the hospital system, and she branched out on her own because like she didn't feel like she had the freedom to do what was best for the patient. And so I do, private practice, I do tend to say network with other private practice,
Right.
because they tend to get it.
Yeah.
You know what I mean? And have some of the same philosophies. Not that you can't work with people in, other settings or systems, but yeah,
Right.
it tends to be easier,
Mhm.
less red tape.
Agreed. Yes, we see that,
Yes.
especially as a lot of like our ENTs are getting into these bigger or
Yeah.
associations and organizations, and now they're like, "Oh, I can't really say that anymore." And it's like,
I can't refer
yeah,
to
like
that.
that's
Yeah.
how you feel. How can you not?
It's like stifling.
Yeah.
And that's another thing is like referrals. Like I want to refer to the best person for the job.
Yep.
That is the ultimate.
Right.
Whether they take your insurance or not, like I don't want to assume if someone can or cannot pay for something, right? Or wants to or doesn't want to. And I had the director of the pediatric GI here, he kind of got his hand slapped for referring to us, instead of like within the hospital system. And he was like, well, Autumn gets these kids eating. Like, if we get therapists that get kids eating, I'll refer in house. That's fine. So it's interesting, just the dynamics of everything.
Yes. Yeah, definitely. And I mean, I feel like you've made such a good and valid point about having the patient go back to the provider. How does that work with your sleep patients? Are they redoing like a sleep study and then they can tell things are improving? Because that's a hard place to show evidence or show progress.
So that is hard because sleep studies are like thousands of dollars, right? And they're not fun. So no one wants to be like, yeah, sign me up for terrible night's sleep with all the wires, right?
Exactly. So that maybe I have a sleep disturbance that's enough for someone to do anything about.
Yeah.
Right, right. And a lot of our people, come with sleep issues, and, they're like, should I get a sleep study? And I'm like, well, that's honestly up to you. I mean, there's kind of 3 factors that I'm like, yes. Okay. If you're falling asleep in my chair, yes, you're going, because you're a liability. If you've had, a stroke, a TIA in the past, you're going. You know, I tell them, sleep studies tell us there's a problem. Well, your symptoms are telling us there's a problem,
Right.
right?
Yeah.
It gives us, it quantifies it, which is helpful. But it doesn't tell us where the problem is or what to do about it.
Right.
Yep.
Right. And the gold standard is CPAP. Well, a lot of people can't tolerate CPAP. And then, I feel like there's so many interventions for everything except the tongue. Right.
Yes.
And fun fact. So I did a presentation. It was the Airways Life Summit, 2023, I think, on airway dilator muscles. And the number one thing that keeps your airway open and you alive at night is the genioglottis muscle. It's been studied the most in humans and animal studies. Like, it's the number one thing. Whereas I feel we stick a CPAP on there and then it just blows at the tongue.
Right.
And
Yeah.
that's when the neck blows off your face. That's when you feel like you're suffocating. That's when you have to pump up the pressure.
Yeah.
So it is helpful to have one, just to kind of know where they fall and have some more objective data.
Yeah.
And if they need a diagnosis, like a medical diagnosis to get some of their treatments covered, then okay, that might be worth it. Or if we're concerned about central apnea, that's a whole nother ball of wax, right? So, we do use like the Berlin and the pediatric sleep questionnaire and things like that to, demonstrate progress. We also are symptom based, like, okay, we'll check in and I'll say same, better, worse. You came here and you never dreamed. Is that the same? Is that, are you still not dreaming? Are you sometimes dreaming? Like, what does that look like?
Right.
Do you still wake up with your mouth dry? How many times a night do you wake up now? You said, 5 or 6 before. Okay, we're down to 2 or 3. So, I do think, I think that's hard. I mean, the cool thing is, we have been able to get some people off their CPAP or off their oral appliance. Obviously, we don't do that.
Yeah.
We are part of that team, and they have another sleep study, and they literally don't qualify as sleep apnea anymore.
Right.
So that's really cool when we can like see that full circle. But yeah, I mean, truth be told, it doesn't happen very much.
Right.
Yeah.
Right.
Okay.
Yeah.
Yeah.
It's really hard. I was wondering if you had the secret formula, because it's true. It's very, very challenging. And forget when you are telling a non-believer that myofunctional therapy can help with sleep apnea, that it's like we're talking, and we might as well be talking in a foreign language, because they're looking at us like, do you really believe that? Or are you,
For sure. For sure. Yeah. Yeah. And I mean, that's just like deep education and, showing all the anatomy and why and whatever else. Yeah, for
Talking
sure.
about the airway conferences. Have you heard of this conference? You should check it out.
They're multiplying.
Yeah.
I'm like, wait, where are we going now? Airway who? Okay, well, that's the one. Okay, we're going to airway, whatever. And I'm impressed, the years, because I just I'm like, what state am I going to? Just put me on a plane when I get there. Yeah. So I'm impressed that you remember.
Yeah, I try. I have a really weird, good memory in that sense. Like every course I've taught, I can see the layout of the room.
Wow.
Wow.
Yeah. And certain people, I can remember where
Right,
they sat.
the face they
So
stared
bizarre.
at you with.
That's so amazing. Yeah.
That's awesome.
Yeah.
Well, we know that you obviously are busy and have things to do today. So before we end our discussion, can you just tell, obviously, so we have therapists and SLPs and professionals that do watch these, as well as patients. But for the professionals watching, how can they learn more about your courses? I know we spoke about some throughout. We haven't touched on your Stones approach. So if you want to talk a little bit about that course, and then how people can find out more.
Sure. Yeah. I mean, where you can find me mainly is Instagram at Crystal_Facial1. We put everything on there. All the links are there. We, share new research and case studies, and any announcements, hop on our email list. That'll give you the rundown. So yeah, the Stones approach. So, okay, let me tell you a little bit of how it came about.
Okay.
So to be honest, I came out of my myofunctional therapy course and I was like, what the what? I don't know. I know the reason you want, correct rest posture, swallow, or nasal breathing. But I now have all of these exercises and I don't know what to do, when, and why, and how to get someone doing them, and in what order, and an order that makes sense. So anyway, I had to like sort it out in my head, right? And so I did that, and I kind of, you don't want a cookie cutter program, right? But you also need some sort of framework, some sort of guiding, concept or whatever. And so that's kind of what the stones approach is. It's basically, I knew I had something valuable. It was how I conceptualized myo in my head when all of our therapists have moved to come work with us, and not a one of them has had a full intro myo course.
Wow.
Wow.
And I trained them from the ground up with the stones approach.
Yeah.
So that's when I knew, like, okay, if I can teach my people this, I have something that is valuable to other people. And I feel like that's a common thing, is like, my head is spinning after that initial myo course. Like, how do I actually implement this and put this into practice? And I was there too. So STONE stands for Systematic Treatment of Orofacial Myofunctional Disorders with Nuanced Effective Strategies.
Wow.
So
Wow.
yeah, it's basically how I put together what I was missing. So we cover like 40 something orthodontic appliances, what they do, how they work, what kind of cases they're good for. Like, that was all like foreign language to me. The different types of sleep interventions, you know, what types of CPAPs are, how to read a sleep study, you know, with the report, things like that. Research, which is so funny. Like, my myo course didn't put research in there. And I need to know that there is efficacy for what I'm doing. So we cover the most up-to-date research on myofunctional therapy in TMJ population, myofunctional therapy in swallowing, myofunctional therapy in ortho. So covering that, and big thing is compensations and how to step down and why things are not working. So one of the biggest questions is like, oh, I'm trying to get someone to be able to suction and they can't do it. And they're like, they can do tongue to spot, but they can't suction. Well, have you worked the back of the tongue? Well, have you worked on the lateral borders of the tongue, being able to create that suction cup? And so really, like, scaling back. And then if they can't do a certain exercise, how to cue to get there.
Right.
That's a lot of what it is. And it honestly, I love this course. It's a really fun course. We like give people a whole supply list to get engaged and get out of their seats and interact and do these different interventions and exercises. So lots of videos, case studies, all that.
That's
so
amazing.
I love it. I think our therapist might need to take that course. We're gonna have Autumn Zoom. We're gonna have you Zoom in from wherever you may be and give them that course, because they all need that crash course. Absolutely.
Yeah. We do it virtual online, but we do it live just because I don't want people to come out having questions. You know what I mean? Like, I want them to be able to get their questions answered, and there's so much. It's packed full. So.
I'm sure they bring a lot of their own patient questions to you too, which is awesome.
Yeah, for sure. So that's my advanced myo course. And then, you know, I have my tongue tie courses and some business stuff, like networking stuff. Working on a lot for this year. So
I was going to say, and you're busy. So, and people are learning, which is, especially even us back, you know, finding you and learning from you has just been amazing. And that only helps our practice that much more. And as Toni-Ann said, we play this in our waiting rooms in the offices. So it does get to our patients and to our families. So that again, they're getting to know you, and they don't always have to come and watch it here. They're watching it. We kind of badger it into their brains while they're waiting.
That's amazing. That's like, now you don't have to have random stuff on like your TV out there. They're also hearing it from other professionals, so it's not.
They know we're not the only two crazy people saying it.
Exactly. That's how it all started. Was like, okay, someone else needs to say what we're saying without. I
love it. I love it. All right.
Thank you so much for spending some time with us and talking. I feel like we could talk forever because there's just so much. And hopefully this will not be the only time. We're going to have to do a supplemental. Autumn, Henning, part two on
Yes.
Talk the Talk, because I do think you have so much valuable information, and I really do think that our patients, our families, and whoever are watching this are really are going to learn a ton, and hopefully take the next step in learning more, whether it be from you or from their own professional, or even taking your advice to go back to their professionals.
Yeah, for sure. For sure. Thank you so much for having me. It was fun.
It was so fun, and
Thank
hopefully
you.
we'll see you in person soon.
Yes, absolutely.
Yeah, for sure.
All
All right.
Enjoy your day.
Thank you so much.
Bye.
Thanks.
Bye.
Thank you for joining us on this episode of Talk the Talk.
We hope it was enjoyable and educational, and further supports you both personally and professionally.
For more information, please check out our Wyo Myo and Myo Minute podcast, as well as our other episodes of Talk the Talk. And don't forget to check out our tongue training appliance, Spot Pal, to help with tongue thrusting, thumb sucking, snoring, TMJ, mouth breathing, and so much more. Visit thespotpal.com.